Now, I would like to thank you so much for for your kind words, Mrs. Berger. Now, I would like to recognize and welcome our guest of honor, Dr. Darren Tishler. Dr. Tishler is the Chief of Metabolic and Bariatric Surgery at Hartford Hospital and an Associate Clinical Professor of Surgery at the University of Connecticut School of Medicine. Dr. Tishler, we are delighted to have you here tonight. Please join us on the stage.
Thank you for honoring me tonight as one of your speakers and guests. You have made me and my wife. Okay. You've made me and my wife, Stephanie, feel extremely welcome tonight. I truly appreciate being able to share in your cultures and traditions. Congratulations on forming the South Asian Women Physician Society. You have, in a very short time, built a very robust community. We are all tied together by communities such as this one. As a dad of two wonderful young women, one of whom is a medical student, I very much appreciate the need for communities for women in medicine. Now, I'm going to take this a little more academic tonight. I know we've been celebrating, but a little more academic now. And as a community of physicians of many specialties here tonight, we are also all connected by the disease of obesity. I know of no other chronic disease that impacts every specialty from primary care to surgery. It leads to health issues and diseases that touch women's health, behavioral health, orthopedics, oncology, and endocrinology. It impacts rheumatology, cardiology, pulmonology, urogynecology, sleep medicine, and emergency medicine. It affects patients of all ages seeing physicians in pediatrics and in geriatrics. This disease affects all races, cultures, and religions. It worsens health outcomes and reduces quality of life, shortens life expectancy, and costs our nation more than $170 billion annually in direct medical expenditures. When it comes to the loss of productivity, the cost of obesity exceeds $1 trillion. Large cohort studies and systematic reviews have identified 21 major overlapping diseases with robust associations to obesity, including type 2 diabetes, hypertension, dyslipidemia, coronary heart disease, heart failure, stroke, osteoarthritis, gout, sleep apnea, chronic kidney disease, metabolic-associated fatty liver disease, and asthma. These associations also include breast cancer, colorectal, kidney, liver, pancreatic, and endometrial cancers. The Global Burden of Disease Study and other modeling efforts have cataloged 27 diseases with convincing or probable causal links to body mass index, including 18 specific cancers, 6 cardiovascular conditions, and other disorders like low back pain and Alzheimer's disease. Beyond these, obesity is associated with a much wider array of conditions, possibly over 250 when considering weaker or less direct associations, including mood disorders, reproductive disorders, and various dermatologic, neurological, and infectious diseases. Although Asian American adults have a lower prevalence of obesity and overweight than adults in other racial groups, they have significantly higher levels of hypertension, cardiovascular disease, and type 2 diabetes at the same body mass index levels. Body mass index alone does not account for fat distribution, as there are metabolic differences in patients with central obesity as compared to obesity predominantly in the lower extremities. As a result, the 2022 ASMBS and International Federation for the Study of Obesity guidelines for metabolic and bariatric surgery have been revised to include in the Asian population a definition of BMI of 25 and above as obesity and a BMI of greater than 27.5 as an indication for metabolic bariatric surgery. The most modern definitions of obesity move us away from body mass index as the defining criteria for obesity. We are now adopting a newer definition of obesity, one that moves the definition to a preclinical and clinical obesity based on the presence or absence of obesity-related health conditions. This landmark work, which was published in The Lancet earlier this year, will help to eliminate obesity bias and stigma that has denied Indian and Southeast Asian populations treatment of obesity due to a low body mass index despite significant metabolic disease burden. Now, when it comes to treating obesity in the GLP-1 era, there has never been a greater time to be a metabolic bariatric surgeon. To quote the most famous of Connecticut authors, Samuel Clemens, "The rumors of my death have been greatly exaggerated." We now have more tools than ever before to treat obesity. My partner, Dr. Devika Umashankar, and I shared a vision for a much greater way of treating obesity nearly a decade ago. Together, we developed one of the first truly integrated, comprehensive programs for the treatment of obesity. We worked diligently to foster this relationship, and at many times it was not easy. Of course, I must ask you, how often do a surgeon and an obesity medicine specialist become partners, trusted colleagues, and most importantly, great friends? I've been extremely fortunate to care for thousands of patients with obesity over the last 2 decades. I still see many of the patients that I cared for when I first came into practice when I had no gray hair. And because of the collaboration that we developed, I have never been more excited about the future of treatment for obesity than I am right now. Last month, as physicians, we helped to promote awareness of breast cancer. I think it's helpful to compare the treatment of obesity to the treatment of breast cancer. With all diseases, we want to start with prevention. Unfortunately, no degree of obesity prevention or interventions have slowed the increasing prevalence of obesity in any meaningful way. To get the best outcomes with both cancer and obesity, we need to have appropriate screening and detection and be able to treat the disease at an earlier stage and younger age. We want to treat the disease aggressively and before it becomes metastatic. Obesity, like cancer, can indeed become metastatic once it has caused irreversible end organ dysfunction or permanent loss of mobility. A physician, family member, or colleague would never tell a patient with breast cancer to try real hard on your own to make the cancer go away. I ask you to reflect for a moment about why some providers and others in healthcare still feel it is okay to speak that way about obesity. We never ask a patient with breast cancer to choose between chemotherapy, radiation treatment, surgery, or hormonal therapy. It is the combination of the 4 that yields the best possible results and chances of a cure or long-term survival. Yet we still ask patients to choose between therapies, or worse, recommend monotherapy as an obesity treatment. Patients are too often told to try another diet, to try another exercise program, try this pill, or try this new injection. Once again, multimodal treatment is best. We must all work to stop the stigma of obesity and end weight bias and offer our patients comprehensive, personalized, and evidence-based multimodal treatments of obesity. As Nivi and other colleagues in my department can attest, this care is best delivered in a non-hurried, compassionate manner by board-certified specialists while at the same time engaging and collaborating with the patient's primary care, endocrine, and other specialty providers. Even in this era of GLP-1 receptor agonists, bariatric surgery remains the most effective treatment for obesity. Early on in the development of bariatric surgery, it was recognized that there was rapid improvement of type 2 diabetes after surgery, and that suggested a link between bariatric surgery and gut peptides. The connection between bariatric surgery and the glucagon-like peptide receptor was first reported nearly a decade before a peptide was isolated from the saliva of lizards and brought to market as exenatide in 2005. That was the first GLP-1 receptor agonist. The safety of bariatric surgery has been long established, studied, and improved. Our participation in the Metabolic Bariatric Surgery Accreditation and Quality Improvement Program has allowed us to continually advance bariatric surgery. Our patients walk and drink liquids within hours of surgery. Less than 2% of the patients in my program require narcotics after metabolic bariatric surgery, and the majority go home the next day. More than 90% of our patients report improvements in quality of life, and on average, we extend life expectancy by approximately 10 years. In this day of AI assessments and video-based interactions with our patients, we can easily lose the human touch that connects us with our patients and builds trust. The term virtual, as in virtual visit, disconnects us from our patients and implies, by definition, that it's not an actual visit. The face-to-face, in-person interaction and connection that you have with your patients makes them more likely to seek appropriate treatment of obesity and metabolic disease. The future of obesity treatment requires nothing short of the collaboration of the metabolic bariatric surgeons, board-certified obesity medicine experts, dietitians, behavioral health specialists, and exercise physiologists, along with many other specialties and allied health professionals. No matter what specialty you are in, take a few minutes to talk to your patients about comprehensive treatments for obesity. Your patients, friends, and colleagues trust you to help them make that decision to seek treatment. That simple connection, compassion, and empathy can allow you to improve the quality of life and overall life expectancy of your patients. Together, we can stop the stigma of obesity. It's my honor to speak to you for a few minutes tonight. Thank you.